Hello, welcome to Health Alert. I'm Pam Butler. Today we're going to talk about issues of nephrology, and joining me is Dr. Malcolm Buford. He is an associate professor at OU Physicians in Tulsa, and he is a nephrologist. Welcome.
Thank you.
Now, before we start, let's get a little background here. What is a nephrologist, so people understand what is it and what do you do?
A nephrologist is an internal medicine physician, so someone who's graduated medical school and gone through an internal medicine residency. And then they've decided to take up special time and study in the diseases of the kidney.
Okay.
So we do high blood pressure management. We worry about kidney failure and patients who are on dialysis, and the way that the kidney affects bones and metabolism and those sort of things.
Okay. Now, when we think about the kidney, because that is your primary focus, let's do a little education here for all of us. What exactly does the kidney do? I mean, sometimes we have a general idea of what it does, and how many do we have? I mean, what does it really do? Tell us a little bit.
Okay, well, that's actually a pretty broad question. The kidney, you have two kidneys.
Okay.
They usually sit right in the middle of your back, if you will. They kind of sit in a jello mold, if you will, called the retroperitoneum.
Okay.
There are about 1 million little filters in each kidney called nephrons, and what they do is they take blood that gets perfused or gets into the organ of the kidney, filters out water and salt and electrolytes, and in kind of a push-pull configuration ends up making urine. In addition, the kidneys secrete a number of hormones. So the kidneys help to regulate, like I said, bone density and strength, that in conjunction with your liver and your bowels and what you eat.
Okay.
It helps to regulate anemia, or hemoglobin, if you will. So in patients who may become anemic from a number of different causes, which is just where you lose hemoglobin or your oxygen carrying capacity in your blood, the kidneys would help to kind of regulate that. In addition, there's a lot of thought that the kidneys help to regulate cardiovascular disease. The kidneys help to determine blood pressure in the way that they manage the salts that they either collect or secrete. So there are many host functions. They also help to clean drugs out of the system. So in conjunction with the liver and the plasma of the blood, medications that you may take may need to be excreted, or its metabolites need to be excreted. And so the kidneys help to do that too.
Okay. Well, the kidney, let me ask this question. And I like the way when you said we, because it shows, doctor, that you're very tied to the kidney.
Unfortunately.
And that is your specialty focus. Now, with the kidney, people may want to know, too, because you talked about how it filters and it helps to help all kinds of systems. Is it affected a lot by, because we hear a lot about obesity, is it affected a lot by what we're eating and the kind of weight we're carrying? Does that really affect the kidney significantly?
Yes, it does. As a matter of fact, quite often I tell patients who are on dialysis, ultimately, that in no other field of medicine the phrase "you are what you eat" is more real. Okay, it's more applicable. The kidneys can actually burn out, if you will, or be overused in the face of obesity. And there's actually a special disease process for that that has a name. They also are, to some degree, responsible for excessive amounts of volume gains or fluid gains or swelling as they fail. So, not only does obesity from, fat gains or a lack of activity or sedentary lifestyle play a role, but also the fluid retention that people may see, so far as when their ankles swell or if they feel short of breath when they lay back. Sometimes that's not heart-related or liver-related. It can be kidney-related.
Okay, because looking at that then, like people who are really trying to monitor their sodium intake or the kinds of things that we get with a lot of soda pop and stuff like that, those are things that are just not good for the kidney to have those high levels of sodiums, or or how does that play into it? Because that's what we think about as the average person, about all this fluid where we're taking in too much salt.
Right.
Or too much sodium.
And for the most part, that's true. And actually, if you can reinforce that, that'd be a good idea. But
okay.
Now, the kidneys, if your kidney function is normal, you should be able to actually handle, for the most part, a pretty high salt diet. For instance, a typical American diet is anywhere from 6 to 9 grams of salt a day. So like if you turn your food over, you know, you look at like the back of a can of soup, you look at the nutritional facts, and you see sodium in milligrams, that's what we're talking about, you know. So the amount of salt that you eat, the kidneys would help to regulate and get rid of. Now, if you have impairment in your kidney function, either because of medications that help to alter blood flow or the way that the kidneys would normally handle salt, or different diseases such as heart failure or diabetes, or if you're losing protein in your urine, those things would make you hold on to water, hold on to salt. And where salt goes, water follows. And so, you know, when you do eat an awful lot of salt, then that does make you retain and swell.
Okay. Well, then when we look at our kidneys, what are some of the most common ways that we can damage them? You did talk about various disease processes. Does it tend to happen a lot with accidents, like if you're in a car accident or a motorcycle accident, or for kids, playground? I mean, what are some of the most common ways that we may not even realize that we're damaging our kidneys, other than just the typical disease process?
Well, you know, not to try and put any pharmaceutical industries out of business, but medications are actually a pretty frequent source of kidney dysfunction in our field. You know, when we get consulted to see people in the hospital setting, generally I would say 80% of causes of acute kidney injury, meaning when the kidneys are suddenly not working in the hospital setting, are you know, pretty frequently they're associated with medications that were given or substances that were administered, that for the most part people would normally handle, but in rare situations, you know, that they may be combined with, they end up causing failure. At home, you know, if your blood pressure is elevated and you're not taking your medications, that's one way that people cause kidney dysfunction. If your blood sugar is sky high and it's not being monitored, that's another way. Excessive use of nonsteroidals, so drugs like ibuprofen, Motrin, Naproxen, those drugs actually can cause kidney dysfunction. Usually that's in the setting of underlying organ dysfunction. So if you have heart failure and you're not perfusing your kidneys well, the kidneys are trying to maintain what's called homeostasis, or just a normal balance. Okay, those drugs actually kind of disrupt that balance and can push the kidneys over into failure. So it's important when you're on medications and you have underlying diseases that you talk with your physician and ask them about some of the rather innocuous over-the-counter medications that you otherwise wouldn't suspect are causing a problem.
Well, what about long-term use? For instance, there can be individuals who feel that I don't really have a disease process going per se, but I get frequent headaches, or I just don't feel well from time to time. So they stay on those over-the-counter medications for a prolonged period of time. They don't even read the bottle that tells you how long you should be on it, and don't stay beyond XYZ. Can that be a contributor to impacting the kidney negatively?
It can. It can. As a matter of fact, if I see someone in clinic and they have a history of 20 plus years of using this particular agent, and we do a thorough evaluation of them, and there are many, many different ways that the kidneys can be harmed by disease processes or occupational hazards and the like. If the only thing that's in their history is this, you know, is a medication that they've used for a chronic period of time, sometimes that's actually the only thing they have. They're usually associated, you know, with other problems or with things that we can find. So like on ultrasound, which is like a sonogram when a woman is having a child and she's getting it checked out, we can do the same thing to look at the kidneys, just like we can at the heart, which is called an echocardiogram. When we look at the kidneys, if they're small in size and if they're highly what's called echogenic, meaning that their density is high, then that is also somewhat suggestive. If they have calcium, particularly, if they have evidence of bone, if you will, changes on ultrasound inside their kidney, that's also highly suggestive of those type of medications being used long term. So yeah, the over-the-counter medications should be used with caution. You know, if we were supposed to have it in us all the time, we would have come with it.
Okay, that's a good point, Doctor. We will take a really quick break on that and come back and look at some more of your kidney.
No problem.
Okay, please stay with us. We'll be right back. Welcome back. To continue our discussion, looking at issues of nephrology, joining me again is Dr. Malcolm Buford, Associate Professor in Nephrology at OU Physicians in Tulsa. Let's jump in. Now, I do want to ask you with our kidney here, I'm getting personalized with it too.
Okay.
How young do you tend to see problems, and what age group do you focus on? I mean, is it more common with real major kidney issues? We always think of getting more mature, I say that versus older, getting more mature, that's where you start seeing all of these issues, but
Right.
is that really the same with the kidney, or does it just vary all over the place?
It does actually. It's not uncommon to have children get kidney diseases. As an adult nephrologist, I tend to only see people who are 18 years or older.
Okay.
But there are pediatric nephrologists or pediatricians who are classically trained in nephrology and deal with, oddly enough, more of the genetic variant spectrum of diseases. So they deal with the glycogen storage diseases, or they deal with some of the hereditary problems that may come about. We do see some congenital or genetic abnormalities like autosomal dominant polycystic kidney disease, where the kidneys will have multiple cysts in them, usually by the age of 20.
Okay.
And that can replace normal, what's called parenchyma, or the functioning tissue, or push it out of the way and obstruct normal function. But oddly enough, kidney function does deteriorate over time, just like our bodies do. Right? As a matter of fact, after the age of 40, there's a general consensus that you lose kidney function at about 1 ml per minute per year. Now, let me kind of put that in more layman's terms.
Please do, because that sounds really scary, doctor, in our normal maturing process.
Understood.
Here.
So let's say that your kidneys start out working at about 90 to 120 miles per hour.
Okay.
Okay. And that's usually about what we would expect in normal kidney function. Okay. We actually say milliliters of blood cleaned per minute. And we typically would normalize that by somebody's, body weight or their body surface area. But anyhow, let's say you started at 90 to 120 miles an hour. At the age of 40, with all things being equal, no high blood pressure, no diabetes, no non-steroidals, no cancer, no chemotherapy, any of those different things, we would expect people to lose function at about 1 mile per hour per year. And so if you go 40 to 80 and you started at 100 miles an hour, then you ought to be 60 miles an hour by the time you're 80. Because you would have lost 40 miles per hour. And so, there is a gradual decline that can result in kidney dysfunction. So inevitably, anybody, if they live long enough, is going to have failure.
Okay, now with this gradual change, therefore, are there things that we should be doing? Like I said, once you hit 40, you start, I almost think of the car where you start to decelerate a little bit.
Understood.
Are there things that you need to do to try to sort of balance that? For instance, eat more carrots. I know we think of that for the eyes,
That's a good thing. Yeah. No.
Or eat more spinach, or, Popeye did that, Are there things that we can do to try to sort of lessen that impact?
There are, and unfortunately, it really comes down to common sense things. Don't eat excessive amounts of salts. Don't drink heavily. Don't use drugs, and manage your diseases that your doctor, tells you to have. Work out a plan, a treatment plan to try and reach your goals. If you know you have high blood pressure, control it. If you know you have diabetes, don't ignore it. It's like I always tell people too. You can choose to not handle this disease, but at some point, it's going to handle you.
Right.
And so it really comes down to just taking ownership and responsibility.
Okay, so some of the normal things that we know to stay healthy are going to help in that area as well. Like you said, not drinking, stop smoking, control your weight, exercising, healthy diets, and you don't necessarily need like an extra vitamin K or extra anything, just those normal kinds of things.
Right. As a matter of fact, for some people who are a little more aggressive about vitamin supplementation, you mentioned, spinach with Popeye. Well, that's kind of high in oxalic acid or oxalate. And that can actually yield kidney stones, which over time can end up with, infecting affecting your kidneys and causing failure. So moderation is key.
Okay, moderation is key versus going overboard with one thing or with the other.
You can do too much.
Okay, and let me ask this question too in relation to looking at the kidney function, because you did at the beginning of the show say, of course, we have two. Now, what about people who were born with one in terms of their ability, or people that donate a kidney? How do they fare, or how can an individual fare with one kidney?
Most of the time, they never know it. So, you'll have people who go through life never really either going to the doctor or having anything come up abnormal in their lab study. So they may not even know or have an imaging study to show it. And it's typically an incidental finding. Now, the people who donate are a different situation. Ironically, they have a lower tendency to get kidney stones after donation. That's a whole other situation. But there is a concern with people who donate eventually needing a kidney themselves or going on to dialysis themselves. And, in the ASN, in the Association, in the American Society of Nephrology, there is a desire to try and make special arrangements or allotments of funds for the people who choose to donate to either get higher up on the transplantation list should their remaining kidney fail, or if they do need more aggressive therapy for blood pressure control after donation, that they should have special vouchers for medications. I mean, that's been discussed and thrown around, and invariably it comes down to finances and politics. But there is some risk for those patients. Of course, they're obviously educated about it. They know about it. They make a conscious decision, an educated decision when they choose to donate.
Because all that gets factored into what is your current state of health in terms of how healthy that remaining kidney would be in normal conditions.
Yeah, and in certain centers that do transplants, like St. John's, for instance, that does that, or St. Francis, or any of the other facilities where I've previously been, like in Washington State, where I came from, we'll have special tests done that actually give us a differential on how much function is left in one kidney versus the other, and typically leave the kidney that is dominant, that functions the best, in the transplant donator, and give the recipient the kidney that's a little less functional, but actually is sufficient to get them either off dialysis or to prevent them from going on.
Okay. Now with the kidney then, because you talked about especially people that are born with just one kidney, people may wonder if you have some kidney disease, or let's say you were born with one kidney, is there a great likelihood in terms of your children, if if the mom, produces a baby, that they will have these issues as well? Because people want to know about that, or is it not necessarily a connection?
That part, quite honestly, I can't comment to that. I'm really not familiar as to whether or not someone who is born with a congenital single kidney has a higher tendency to yield offspring that also will have that problem. I would suspect not. Those type of abnormalities are fairly infrequent, though they can happen, like horseshoe kidney or some of the other abnormalities, and they're usually picked up fairly early. Also understand that people who do have pathologic, what's called agenesis of the kidney, like it doesn't develop, they're usually found pretty early, and if they they're usually found pretty late, 40s, 50s, and so they may have already had, children. There are some genetic diseases or some processes that happen, like I mentioned polycystic kidney disease earlier, where we do recommend that people have screening, have surveillance, either in siblings or in parents, or usually the family history come down. There are some patients who are what we call spontaneous mutations, which sounds horrible.
Yeah, it does.
But the reality is that they may develop PKD de novo, just within themselves, or have had it from birth.
Okay, now what's PKD? Because people like, he said
polycystic kidney disease.
Okay, right.
And they may, still pass it along to their children, but it's more for awareness and prevention. So if you know at 20 or 21 that your parent had polycystic kidney disease, and you know that you shouldn't, eat excessive amounts of salt and watch your blood pressure and the like, then you can make intelligent decisions about how you gear your life, how you live it, and then you end up preventing possible end-stage renal disease and the need for dialysis.
Okay, yeah, and then talking with your physician about what are your risk factors and how can they determine is always a good way to go in terms of the questions that you have.
All right.
Okay, well, you stay put, because we're going to come back and talk. I want to really focus on dialysis as well.
Okay.
All right. Please stay with us. We'll be right back. Welcome back. To complete our discussion talking about nephrology issues, joining me again is Dr. Malcolm Buford. He's Associate Professor at OU Physicians in Tulsa. Let's jump in.
Okay.
Now, I want to focus a little bit about dialysis and kidney disease and dialysis. Do you see it more prevalent in certain ethnic groups compared to others, or does it tend to be kind of flat across the board? Tell us how that looks.
Actually, it is more common in minorities. In blacks and Hispanics, it tends to happen more readily, probably because of socioeconomic factors. Okay, so there's a lot of debate as to why kidney failure would happen more readily in what we call minority populations. Some of that has to do with access to health care, has to deal with income. For instance, just in Tulsa alone, if you plot out by demographic household incomes in 2000, the median household income on average with everybody was $38,000 a year. With white native Tulsans, it was $41,000. With Asians, it was $42,000. But with Hispanics, it was $29,000, and with African Americans, it was $22,000. There's also disparity based on geographic boundaries. So in the Commonwealth consensus data that was presented several years ago, showing the 14% disparity in survival statistics between North and South Tulsa, which is one of the reasons why OU was so active in trying to recruit physicians and change our name to the School of Community Medicine and the like. There is a disparity in access to health care and the ability to pay for medications and travel. With that, we do tend to see dialysis more often in those patients who can't have access, who can't get their insulin, who don't have access to more refined foods, end up eating more salt-laden substances, so their blood pressure and their diabetes is out of control, and they obviously would have a tendency to develop kidney failure more readily.
That is frightening, and to see those kind of disparities, and to know that it is a healthcare crisis, is it not?
It is, and it's not just Tulsa. I mean, it's a nationwide
right. It's throughout
problem.
our country.
It is.
Now, how do you foresee? And then I do want to get into some specifics of what happens when a person goes on dialysis. How do you see healthcare initiatives that are being talked about in the country in terms of access, working with that to maybe reverse that? Will it allow more people to have the access that they need to healthcare?
It will. To
and
some
support
degree.
medications and things like that?
It will if they utilize the services.
Right.
Obviously, there is still a great deal of distrust in certain ethnic minorities regarding health care. And to some degree, we have to try and get beyond that. There's also limited funds. And so when we look at dialysis and its origination, and when the government decided to start paying for it, Carl Gottschalk out of Harvard had done a study, or had done a consensus committee, and that was in 1967 and 72. His paper and what's called the Bruton paper were presented, looking at whether or not dialysis could even be funded for the layman. It was, but with parameters that are grossly under what we're currently using. So it is important that people learn more about what is becoming available soon, and utilize that to their advantage, or they'll be without even more.
Okay. Well, with dialysis, in our last few minutes here, when a person has to go on dialysis, does that tend to be something that they have to do every day? Can it be once a month? I mean, what can a person sort of think about? Because sometimes is it based on how much kidney function is left, or do you go on dialysis if you have any kidney function left, or does it have to be just totally gone?
Those are all excellent questions.
And I only have a few minutes.
Right. Dialysis is done when your clearance, your miles per hour, gets down to a certain level. So in patients with diabetes, if your clearance is less than 15 miles per hour, or if you don't have diabetes, less than 10, even though you may still pee, and oftentimes pee more often, people will have to go on. And what was the
Does
remainder
it,
of your
does it
question?
have to be every day, or
No.
can it be once a month? I mean, it does depend.
Right. It's usually 3 days a week
Okay.
for blood or hemodialysis in particular. It's usually 3 days a week, 4 hours a day, and it's 12 hours a week. Well, when the kidneys are working 24/7, 168 hours in a week, we're asking a machine to do in 12 what your kidneys do in 168. The shifts are fairly abrupt on the machine. So it's important to be, consistent, to show up routinely, which we do have a problem with oftentimes with patients on dialysis.
Okay, now if you're on dialysis, do you have to take certain kind of medications? Are there certain things like that that the person needs to be aware of?
Yeah, we tend to give medications that help to replace the function that the kidneys would otherwise using. So building up blood, maintaining bone density, we give replacement meds for that.
Okay, and if a person goes on dialysis, is that what is covered under the insurance umbrella, or should be, or is it something that just the basic cost of the dialysis has all this other stuff in it that you need?
That's changing,
Okay.
and that's actually what I was getting at. So dialysis itself is covered by Medicare and by private insurance. With what's called the bundling process, though, they're now taking some of those medications you were just asking about out of the overall funding. And now that's going to have to be burdened, taken on by the patient, which is unfortunate. That's going to be a negative change. It'll be more difficult for patients to get good quality care. So we're trying to change that, obviously. In the ASN we're lobbying against that, but we end up having to deal with, that's why it's important for people to really learn about what's becoming available for them.
What's going on? Let me ask this last quick question here in terms of dialysis. Once you're on it, of course we know ultimately you might end up with a kidney transplant and that, depending on the failure rate and all that. But once you're on it, can you get cleaned up enough where your kidney starts functioning a little bit better and you can get off of it?
Acutely in the hospital setting, that is the tendency. Chronically in the dialysis unit setting, without transplant, it's unlikely.
Okay. Thank you for joining me. I'll have to have you back for some other discussions. Thank you so much.
Thank you.
Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear comments, questions, or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Or if you're on the email trail, please email me at healthalertusa@gmail.com. And also visit me on YouTube at youtube.com/HealthAlertUSA. Take care, and remember, talk to your physician, find out about your kidney status, get your regular physicals, and whenever you have trouble, talk to your doctor and do the things that you know that you can do to help out and to survive. Take care.